So I welcome you all to this session of conceptual anesthesia. So today in critical care session, we'll be talking about newer antibiotics in critical care. So firstly, we'll think why is there is a need for having newer antibiotics. There are so many antibiotics that we all know of. Why do we actually need a newer antibiotic? And then how are the newer antibiotic pipeline coming as of now in gram positive and negative? And we'll be talking about in 2 3 slides about around 7 to 10 newer antibiotics. So, firstly, why do we need newer antibiotics? So, it has been seen in the last 2 decades or so that more and more use of the antibiotics, more and more irrational use of the antibiotics, and this is leading to multi drug resistant pathogens. So, nowadays we are focusing on what we call as antimicrobial stewardship, and each and every hospital is having programs, each and every hospital is having committees. They are forming a group of 2 3 4 people who are actually seeing whether the correct antibiotic is going on, whether the correct dose is going on, whether we could improve according to the pharmacokinetics and dynamics of the particular antibiotic. Is a high-end antibiotic needed for a specific thing? Can we downgrade the antibiotics? Can we de-escalate the antibiotics? So this is the norm nowadays in all at least secondary and tertiary care hospitals. And the reason for this is that there is a rise of multi-drug resistant pathogens. Infections are often severe and life threatening, and they are usually resistant to many antibiotics which are there in the market. And there has been resistance patterns in the bacteria, and it is spreading from one bacteria to the another. So, resistance is spreading, and nowadays that is why the colonies of bacteria which are resistant to the antibiotics which are already there, they produce larger and larger colonies and cause life threatening infections. That is why we need newer antibiotics. But at the same time, whatever antibiotics we already have, whatever antibiotics we will develop, we have to be very rational in the use of them. So, as we all know, in most of the ICUs worldwide, gram negative bacteria causes around 60 to 70% of infections. And resistance patterns are much more higher in gram negative bacteria. And the terminologies like carbapenem resistant Acinetobacter baumannii, they have developing short forms like CRE, CRAB. So this is called CRAB, carbapenem resistant Acinetobacter baumannii. It's called CRAB. Then carbapenem resistant Pseudomonas is called CRP. So it is so prevalent nowadays that they have developed mnemonics or short forms for this. So just imagine how much is this problem significant. And this has also been seen by the WHO. It's not that only we are facing it or you are fuel facing in your ICUs. It is a worldwide problem. So that is how this WHO report tried to divide the pathogens into critical priority ones, high priority ones, and medium priority ones. The three are the critical priority ones are Acinetobacter baumannii, especially carbapenem resistant. Then Pseudomonas aeruginosa, again carbapenem resistant, and Enterobacteriaceae, which is resistant to carbapenems, as well as third generation cephalosporins. These are all critical priority ones. And higher priority include Enterococcus faecium, which is vancomycin resistant, MRSA or VRSA. MRSA is methicillin resistant Staphylococcus aureus. VRSA is vancomycin resistant Staphylococcus aureus. Then clarithromycin resistant H. pylori, fluoroquinolone resistant Campylobacter. So if you go through them, they are mentioning resistant. That is how much prevalent the resistance is, and that is why we need more research and development for getting newer antibiotics. That is why the stress on the correct usage of the present antibiotics. So just to tell you how is the evolution of antimicrobial resistance, when we develop an antibiotic, we find that most of the organisms are susceptible to it. But over the next decade, what happens is that it develops resistance. Small number of bacteria which are resistant or intrinsically resistant to them or develop resistance, they spread to the other bacteria, and slowly the resistance in the major portion of the bacteria are there, and that is why we are having this problem of multi-drug resistance. So very well said, drug resistance follows the drug like a faithful shadow. So if you see, since 1930s to 2005, whatever antibiotics have been developed, in a matter of a decade or two, previously it was slightly longer, nowadays it is slightly shorter. So antimicrobial resistance develops. So top 10 isolates, if you talk about, this is the bacteria you will also face in whichever ICU you will work. Enterobacteriaceae, Klebsiella as E. coli, Acinetobacter, Pseudomonas, Staphylococcus, Enterococcus, Enterobacter, Proteus, and so on. So when they compared this was a beautiful study which compared the number of lives lost to various diseases like cancer, cholera, diabetes, tetanus. They found that by 2050, antimicrobial resistance will be one of the major causes of death, which death can be attributed to. So we have to take it very seriously and we have to conserve our antibiotics. So beta-lactam antibiotics, which was the mainstay. If you talk about penicillin, then developed cephalosporin. We all know about cephalosporins. We have a throat ache, we take a oral cephalosporin. We have a patient who comes to our critical care settings. If you ask me, so it's one of the second, third generation cephalosporin, one of the first antibiotics that you prescribe. And then slowly and slowly carbapenems in patients who are much sicker. So beta-lactam antibiotics are often the antibiotics of choice in the ICU, but they can be inactivated by beta-lactamase enzymes. And this is the most common and the most important mechanism of resistance in gram-negative bacteria. So all of you who are serious about practicing critical care should be aware about beta-lactam antibiotics as well as the beta-lactamase enzymes and the classifications. So it is called by Ambler classification. And if you work in the ICU, these terms will be very familiar to you because nowadays it is talked in these terms only. It is developed divided into class A, class B, class C, and class D. And here we see the prototype of the enzymes which is there. So if you ask me, class A, the typical enzyme that we talk about is KPC. In class B, we have VIM, NDM. In class C, we have AMPC. And in class D, we have OXA. So if you see the color coding, the red ones, especially they are the carbapenemases. And especially Ambler class C, this is a broad spectrum, one to affect almost all the beta-lactams. So these are types of beta-lactamases. So they are all types of beta-lactamase enzymes. So it can be classified into four molecular classes. I have given example and how it produces resistance into the most common things. So class A, we should know about KPCs that confer resistance to cephalosporins and to all carbapenems and ESBL. So what is ESBL? Extended spectrum beta lactamases. These are conferring resistance to cephalosporins. Then class B typically is what we call as the metallo-beta lactamases, such as NDM, VIM, and IMP, which can lead to resistance to almost all carbapenems except monobactam. So typically what we call as astronam, it is a monobactam that is commonly used in patients who have this metallo-beta lactamases. Then class C example is AMP-C. It is usually chromosomal but sometimes can be plasmid transmitted also and in confers resistance to cephalosporins. Class D commonly called as OXA. This also confers resistance to mostly to carbapenems. So just try and remember the examples. Class A KPC, Class B MBLs, ESBL is also Class A, Class C AMC and D is OXA. So if you talk to me about a decade and a half back, carbapenems, and still at some places it is the antibiotic class of choice when you have a gram-negative bacterial sepsis because maximum resistance that is produced is ESBL or AMC beta lactamases. But over the time, carbapenemase producing resistance is also increasing. So carbapenemase production refers to resistance by beta lactamase production encoded by transmissible genes. And these genes can be possessed by enterobacterales